we had started this electrolyte imbalance, which is the person who is studying it and the person who is teaching it, all of them become having some electrolyte imbalance. So it's a very difficult topic, one of the most difficult topic to understand and interpret, even manage. Okay, because what happens that if you are treating one thing, other thing will come, and if you are treating the other thing, the third thing will come. If you are treating potassium, you have to treat magnesium as well. If you are treating hyponatremia, it may end up it becoming hypernatremia. So that makes it very difficult and challenging. And because the pathology involved is sometimes quite complicated and difficult to address. Okay. So before some more people join, because actually I sent the link a little earlier there than the normal routine. So maybe some people, I will just try to, again, as I did previously, I will just try to recap. We had started the basic concept of fluid balance, and then we discussed how distribution is being strictly under control and is rapidly changing between intracellular and extracellular compartment, and what are the factors which are driving it, and that is aldosterone, ADH, ANP, BNP, renal control, and then trans compartmental shifts. Okay, in which the basic concept is that water will pass through the cell membrane. However, the ions will not move freely. Okay, so so any change in water concentration will have more effect. So that these are the basic things. So we already finished some things about hyponatremia. Okay, and today our agenda is to do some more in more detail this hypernatremia. Before I will just show you some things. I will just use this time to just tell about this link. Okay. Usually I send this link quite frequently, and if you want to just probe it, it will be easier for you. All the review articles and some of presentations, I just recently took a subscription of a website from where we can download a lot of presentations. So I just I'm using that one as well now. So I'm putting it up in the relevant folders. Okay. So you can have just like, for example, if you want to see this electrolytes, you will find it here. So you will go here, and then it has all acid-base balance and blood problems and fluid therapy, and then you will find electrolytes here. And then in electrolytes, I will keep on updating it. Sodium, I just put it, and the general things are actually sodium is more difficult, and rest of electrolytes are relatively simple, though they are all interlinked. Okay, so that is, I think this is, I am already open. Okay, so we will, I think we will just start now. Okay, so actually, as we discussed related to the disorders of sodium imbalance after head injury, in that discussion we have discussed about SIADH, in which sodium, this ADH is becoming too high, and the opposite to it is either absence of ADH, or as in case of central diabetes insipidus, or in case of nephrogenic, in which kidneys fail to respond to conserve water. So it will all result in this because water will be lost, and the concentration of sodium will become high. Okay, so this is the basic concept. This will be one of the form, and other form will be related to any loss, hypotonic fluid losses, like as occur in for example diarrhea, vomiting, okay, sweating. In that way the in the remaining fluid compartment, the sodium concentration will become higher. Okay, so that is the basic mechanism behind it. So just a second. Yes. So it is more than 145, we say it is hypernatremia. Okay, and it is very common, and it has leads to a high mortality and prolonged ICU stay. So as I told you that either it will be primary, yes, the other one of the reason will be water deficit, and the other reason will be sodium gain. Sodium gain is relatively less common as compared to hypotonic fluid losses, which occurs during diarrhea and things like that. Okay, so sodium gain or hypernatremia distributes in the form of, for example, if the patient was hyponatremic and you correct it and you overcorrect it, so it will lead to hypernatremia state. And because the problem, if it occurs acutely, what will happen, it will shrink the water from the cells, and it can cause severe condition that is called as myelonesis. So that is the reason that hypernatremia is a very serious condition. Okay, if it is persistent, then just a second. Okay. Usually they are compensated, and if it is not compensated, then because either it is compensated by the usually we will drink more water if the sodium levels become increased, so we will drink water. So if this mechanism through hypothalamus does not work, that then it will result in hypernatremia. So the patients who are not conscious, or who are not who are like in a condition, dementia or things like that, who are not responding to this mechanism which we usually do, so that will result in hypernatremia. Okay, so impaired thirst response may occur in situation where access to water is limited. Okay, handicapped or bedridden patient and having any neurological problem. Okay, elderly individuals in Western countries, this is a big problem. Okay, and I'm just repeating it again and again, that there will be hypotonic fluid loss, then it will result in hypernatremia. Because if you understand this thing, that it will become easier. Okay, so either it will be renal or it will be non-renal. Non-renal will be either through GIT in the form of vomiting or diarrhea, and this one mainly diarrhea. In vomiting, it can also occur, but more common will be diarrhea. In vomiting, that usually if it is more water loss than sodium loss, then it will occur. Okay, so evaporation through skin and insensible loss, and osmotic diarrhea, which is resulting in more. There will be osmotically active substances which will be leading to this condition. Osmotic substances, even if we use mannitol IV, this will also result in similar condition. Okay, and in hot weather or fever, this may also lead to hypernatremia. Okay, burns, because there will be loss of water, it can also result in hypernatremia. Okay, so renal water loss will be in the form of sorry, osmotic diuresis or diabetes insipidus. Osmotic diuresis occur as it in diabetes mellitus, or if we have taken some hyperosmolar substances. Sorry. Okay. In addition, urea generation from accelerated catabolism, high protein feeds, and stress dose steroids can also result in osmotic diuresis. This is something new for me. Stress dose steroids can cause osmotic diuresis. Okay. And how we will check it? We will check it with the urinary sodium. Okay. What will be the effect in, if for example, usually if it is related to ADH, what will it do? If ADH is not there, then there is a high osmolality in the blood, and because more water is going down, so the urinary concentration will be less. Okay, so it will be less than 10 millimole per liter. I will show you in this in the short while. But if it is due to some other cause, usually body will try to conserve. So in that situation, the urinary sodium will be more. Okay, where body is trying to conserve water. So in that condition, the urinary sodium will be high. Okay, so hypernatremia secondary to non-osmotic urinary water loss is usually caused by impaired vasopressin secretion. Either it is central or nephrogenic. And partial defects occur more commonly than complete defects. It will have a mixed picture. Patients with diabetes insipidus generally do not develop hypernatremia if they are able to maintain fluid intake adequate to compensate for the water loss. So it may be compensated if they are taking more water. The most common cause of central diabetes insipidus is as in occur in trauma or neurosurgery or neoplasms. Okay. This nephrogenic diabetes insipidus may be either be inherited or acquired. Any one of you have just idea about nephrogenic? Because I think it is mainly because of the medications usually. Okay, the later often results, this nephrogenic diabetes insipidus may either be inherited or acquired, and the later often results from a disruption of to the renal concentrating mechanism due to lithium demyxylocycline, which is also used in certain conditions, antibiotics like amphotericin, and hypercalcemia and hypokalemia will also result in this condition. Okay, so these are the causes for, and if the patient is okay, gestational diabetes insipidus. I told yesterday about it as well, that there is circulating placental protease with vasopressinase activity leads to reduced circulating this ADH and polyuria, often accompanied by hypernatremia. So this will result in this condition. Like ADH levels are decreased because of some enzymatic activity of the placenta. So this will result in more urination. Okay. DDA, desmopressin is an effective therapy for this syndrome because of resistance to vasopressinase enzyme. Hypernatremia due to primary sodium gain. Okay, that occurs when we are giving too much correction of this acidosis, metabolic acidosis by bicarb. Okay, so soda bicarb will increase a lot of sodium. Okay, and then it may be due to decreased capacity to excrete retained sodium. It will kidneys will not be able to excrete this overload. Okay. Mineralocorticoid excess will also result like that, because the aldosterone retains sodium and excrete this one potassium and hydrogen. Okay, so in that condition there will be concomitant alkalosis as well, metabolic alkalosis. So transcellular water shift from ECF to ICF can occur in circumstances of transient intracellular hyperosmolarity, as in seizures or rhabdomyolysis. Just okay. So what will be the clinical features? It will be altered mental status, weakness, okay, irritability, because contraction of brain cells. That's the most important thing. Okay, and it will result in encephalopathy, seizures, and it can even lead to mortality. Okay. Osmotic damage to muscle membranes also can lead to these are just some terminologies, because okay, so how to diagnose it? Usually more important thing is to have a good history, and there will be some apparent cause preceding to these readings. Okay, and then physical examination. Patient maybe, because hypovolemic hyponatremia is more common. Okay, so you will just try to have any relevant condition which may be the cause. So you see, in hypovolemic hyponatremia, loss of free water and sodium, total body water is decreased, total body sodium is decreased, less than total body water. Okay, and the feature will be signs of hypovolemia. So there will be hypotension, tachycardia, dry mucous membrane, and as we discussed, that there are renal causes because of osmotic diuresis, or because of some causes related to diuretics, and extra renal like sweating, burns. So this is just a repetition of what I told, that urinary osmolarity will be high, and urinary sodium will be low. Okay. So in euvolemic, there is loss of free water, and total sodium will be normal. Normal water size, no edema. Okay, renal causes central. This is diabetes insipidus, as I told you. And extra renal causes are hypo. We are taking less water, so there is resulting in hypernatremia. Okay. In that condition, urinary osmolality will also be high, and urinary sodium will be variable. Because why? That's I told you that in case of this diabetes insipidus, urinary osmolality will be low because more water is going out. Okay, and extra renal causes it may be high. So the last is hypervolemic hyponatremia, in which there is gain of free water and sodium. So there is increase in volume and increase in sodium. So sodium is more. So in that case, as patient is taking this soda bicarb or tube feeding, hypertonic, and post dialysis as well, if it is this hypertonic dialysate is being used. Okay, so the first thing to, when we are probing it, to see the volume status, if it is hypovolemia, okay, so more decrease in water than sodium, and either it will be in case of renal losses, the urinary sodium will be more, and extra renal urinary sodium will be less. Okay, so similarly, if it is euvolemic, so you will see the variable sodium, urinary sodium. Okay, mainly it is related to diabetes insipidus, but in that cases the urinary osmolarity will be less, as I told you, because free water is being lost. Okay, so your osmolarity will be decreased, and similarly in hypervolemic, urinary sodium will be high. Okay, so in case of hyperaldosteronism or Cushing syndrome, hypertonic dialysis, as I told. Okay. And to differentiate between nephrogenic and central diabetes insipidus, it is through this desmopressin. Okay. This water deprivation test, it has written, I have never seen it being done. For example, if I will just skip. Any questions or any comments, please? Yes, Mauzama, would you like to discuss anything? Yes, Azhar, you are here. Azhar, can you share any questions which were being asked in the previous exams, other than calculation of replacement? Any other question which you remember?
I don't remember the exact question, but what I can say that usually they ask differences in cerebral salt wasting syndrome and SHART one, and other things that some say that patient is urine volume is this much, like 600 ml in an hour, and so what is the so this is basically acha, yes. And other question is regarding their treatment. This is how they have been changing the questions. This is
okay, so like they will be asking you whether you want to give isotonic saline or you want to give hypotonic, in any condition, like if we just try to understand how to treat it. If we have a hypovolemic hypernatremia, so what will we do? What should be the treatment?
Sir, we will give water.
No,
only water.
No, we will give normal because there is hypovolemia. If we will give, like I will explain to you why. If you will give, this is ECF and this is ICF. Okay. So what is happening in this sort of, this is osmolarity and this is volume. Okay. So here what has happened, that osmolarity, this hypernatremia has occurred because of low volume. Okay. So it has like become like this. Okay, so ICF volume will be shrunken to maintain the neutrality. So ICF volume is also shrunken. That is what is cell shrinkage. Okay, so now if you give water, pure water, what will happen? Where will it go?
Intracellularly.
Yes. Okay. So it will affect intracellular, but it will not affect. So that is why you need to give normal saline initially. And then later on, when volume is, you have replaced the volume, then if you need it, you can give free water, or even you can diurese. And the volume, when you have achieved the adequate volume, then next step may be diuresis along with free water. Okay, you understand now?
Yes, sir.
What else? You have
Regarding their treatment, sir,
hypervolemic.
and difference in SAD and cerebral short wasting syndrome.
Okay, I will tell you. Actually, this cerebral salt wasting syndrome I told here. Please, just a second. So in cerebral salt wasting syndrome, there is decreased sodium and there is decrease like water, or you can say volume. Okay, and SIDH there is decreased sodium, but there is either euvolemia or increased volume. Okay, so this is how you will differentiate. Okay, so now how will you treat hypervolemic hypernatremia?
Sir, diuresis?
Diuresis.
Or restrictions of fluid.
Diuresis. Just a second. I will just have a look at this document as well. It will be just a revision. That factor to predispose gain of sodium or loss of water. Factor which interfere with the thirst. Okay. Failure to sense thirst, unable to ingest water. Okay, this is very nice actually to understand that usually when there is gain in water, you will result in more water. But if it is not, you are not able to take it, then it will result in hypernatremia, or there is loss of water and you are not able to ingest water. It's very nice. Okay, so this will be the, so although these are two defense against hyperosmolarity, thirst alone is able to prevent hypernatremia. So that is the chunk of the, before I even repeat, spoke the same thing, that if you are able to take the water, hypernatremia will not occur. Okay, so gain of sodium through this hypertonic dialysis or hypertonic saline or hypertonic any fluids, your hypertonic tube feedings or TPN. Okay, excessive salt added to infant formula, excessive salt tablet ingestion, and increased mineralocorticoid activity. These will all gain. Okay, so what will this hyperenism, renal artery stenosis, congenital adrenal hyperplasia, and the other maintenance for it is water loss. So as we told, sweating, burn, evaporation, okay, hyperventilation, dry gases we are giving, or in the form of central or nephrogenic diabetes insipidus or osmotic diuresis. Okay, I think they have explained in a very nice way, I suggest. Okay, gain of sodium, iatrogenic, excessive ingestion, iatrogenic with renal failure after hypertonic dialysis. These are the same. This is just to understand. Okay, if you, because it needs, it's more stress so that you will be able to swallow it. Okay, so another way they are explaining here, mineralocortic activity. So they are making more sodium and water to be absorbed. Primary aldosteronism, congenital adrenal hyperplasia, hyperenism. Okay, so at the this will be MCQ. Mineralocorticoid at collecting tubules, distal convoluted tubules. Okay, and the most important, aldosterone occurs in primary aldosterone and hyperenism. They're just explaining. Okay, so that's what important, that why if you are reading only one book, you will not be able to understand, because you are reading from the chapter of electrolyte, and this whole endocrinology comes. So if you don't understand those things, there will be missing link. So you should be understanding, and then you will be understanding that you should be taking it together. There will be hypertension, there will be hypernatremia, there will be hypokalemia, there will be metabolic alkalosis. Okay, due to the phenomena of pressure natriuresis, hypernatremia is usually mild. This will be only if kidney functions are good, otherwise it will not occur. Pressure natriuresis is spontaneous excretion of sodium which occurs with increased blood pressure. Okay, so they have explained about primary hyperaldosteronism and Cushing's syndrome. primary hyperaldosteronism, how it will occur? To some tumor, adrenal adenoma, adrenal hyperplasia, or adrenal carcinoma. Okay, then it is benign or just increase activity. So they have, you can read from it, but the basic concept is the same. Okay, Cushing syndrome. Cushing syndrome will be because of excessive this. What is difference between Cushing's disease and Cushing syndrome?
Sir, Cushing disease is central.
Hmm.
And syndrome.
Yes, you
is
are right. Yes, you are right. Cushing disease is basically a disease of that adrenal, that pituitary, and the Cushing syndrome is when it can be due to ingestion of corticosteroid or any adrenal gland tumor or hyperplasia.
Like Cushing's disease
Okay,
is
you are right.
Cushing's disease.
ACTH more from the pituitary in disease, and
Yes.
in syndrome, adrenal is involved.
No, listen, just you are right, but I will just add on to it. If the increase in cortisol is because of pituitary, it is called as Cushing's disease. And if it is because of any other reason, you are taking exogenous or there is some problem in the adrenal directly who are excreting, so that will be resulting in Cushing syndrome. Okay, clear? Because there will be relation of ACTH. Okay, ACTH is secreted from anterior pituitary. So there is involvement, there is central problem, and it is related to the control mechanism. So who is becoming autonomous. So there is ACTH production, and it you see there may be in some neuroendocrine tumors, there may be ectopic ACTH production as well. Okay, not coming from directly from pituitary. So this will be so, and there will be, you see, in elevated in Cushing syndrome, elevated cortisol suppresses pituitary ACTH. So this will be a differentiating point, that ACTH will be high in Cushing's disease and low in Cushing syndrome. Okay. So loss of water, they are telling extra renal through sweating, through intestines, through lungs, through kidneys. Okay. So I think this is a very nice source. I just I don't know from where I find it. I just put it here. So it is easy to understand. Are you with me? Please, because I took a lot of time to go slow, but inshallah today we will finish hypernatremia, and in tomorrow we will do potassium. Okay. Tomorrow it will be at 3 p.m. Pakistan time. If it is nothing else happen, I will take a class at 3 o'clock. So insensible, they are just explaining. I will just try to open from, I will just try to explain in detail about the process of diarrhea, because for that we need to go in the details of physiology. Only then we can understand what really happens, where at which place, which ions are in which place, which thing is being reabsorbed. Only then we can understand. Okay. So Usman, do you want to comment anything about hypernatremia, because you joined lately, because we just said that either it will be increase in water loss or increase in sodium heterogenically by some source, and that is resulting in hypernatremia. So either it will be hypovolemic, either it will be hypervolemic, or either it will be euvolemic. Okay. So any questions, please?
Sir, my question is, aldosterone acts on distal convoluted tube, and Here it is written collecting tubules.
I think there is some mistake. It is distal converted tubules. That is the collecting duct at which ADH occurs, and distal converted tubules this occur. That's why you see, never trust any single source. This is one small example. Okay, because if anything which contrasts or collapse your basic concept, okay, you should never follow it. Okay.
Oh, okay, sir. My second question is in ICU settings during our rotation, I saw consultants give IV 5% dextrose water for hypernatremia.
So
And
Yes, we give.
we cannot give free water, but we can give 5% dextrose water, because if the kidneys the insulin mechanism is correct, the dextrose will be used and the free water will work as a free water. Okay. So
okay, also if it is a dextrose, then inside the plasma it is consumed as glucose, and water is again free water.
but
Yes, basically we give 5% dextrose in order to prevent hypoglycemia to the patient.
no, this is not the reason. It will cause diuresis. So at the same time, you are maintaining the volume and you are causing a diuresis, which will lead to loss of sodium.
No, sir, I think why we are not using distilled water or any other free distilled
That is
water?
because it will cause RBC hemolysis.
Sir, but both are hyposmolar. 5% dextrose is also hyposmolar. It is not isosmolar. If we give 5% dextrose to the normal patient, that will also cause RBC hemolysis.
I think there is some difference between 5% dextrose water and if you are giving free water. There is some difference.
Sir, I think we give 5% so that the patient cannot go into hypoglycemia. That is what I think. Because both are the distilled water is also hyposmolar, 5% is also hypo. If we give 5% dextrose to the normal patient, it will cause hyposmolarity and RBC hemolysis.
Okay, any other comments about it? Because my understanding is
Sir, 5% dextrose is not given for hypoglycemia. Here we are treating only hypernatremia.
No. I'm not saying to treat hypoglycemia. I'm saying to prevent hypoglycemia.
no, but why there will be
Why hypoglycemia?
yes.
Sir, if we give distilled water, it can cause hypoglycemia. We give 5% dextrose. I think that's what I.
No, I will.
That's my understanding.
I will try to find the answer because it will only waste at the moment. I will try to find.
Sir.
This is a very logical question. If anyone has any comment, anyone can help us in this concept. But I think there is some reason. That's why we are not giving free water, because free water will definitely cause hemolysis, but 5% will not cause hemolysis. 5% dextrose water. We are giving.
One thing is 5% is not a hypotonic solution, it is isotonic solution.
No, I have doubt. Let me check it. 5% dextrose is not isosmolar.
No, sir, all dextrose are, I think, isotonic, like ringer and normal slide.
Okay, let me check. But I think so 5% is not isosmolar, it's hyposmolar. Let me check.
Any other comments? I'm just scrolling through it.
This you have shown us one banana. Please explain about its mechanism.
What's this? Up?
Yes, sir.
This is the same diarrhea, sick infant, fever, increase in sensible loss resulting in hypernatremia, and actually the stress response is including hyperglycemia. So it is causing hyperosmolarity and loss. Okay, so infants with infectious diarrhea are at risk of developing dangerous high osmolality from combination of hypernatremia and hyperglycemia. That's what he is explaining. So that one is not correct. I think that dextrose water we are not giving for prevention of hypoglycemia, because in stress there is already hyperglycemia. Okay.
Okay, I think there can be some other reason.
I will just try to find the answer. I will give it to you in the next session, inshallah. I will try to answer this thing.
Sir, actually, oral water we can give, plain water, but IV we don't have water to inject inside the patient. Only source of water which is available, this is in the form of dextrose, and 5% when goes inside the body, it will be consumed in the form of glucose, and we will get free water.
Yes, that's what I understood. I understood as well. Okay, but if it will not cause hemolysis, that's for sure. But what's any other point? I will try to search. Okay. So inshallah, I think if anything, any concept, because I think this is a very nice source. If you people read it in detail, it will give you a very good concept. It is there in the link. I will share the link for it as well. I liked it actually. The way they have explained, it's very nice. But there is repetition for it, we have discussed. So inshallah, in next
Sir, in Google it is written 5% is hypotonic. I've just searched it.
Hypotonic and isoosmotic. Just have a look. Is it also isoosmotic? Because there is
no, it's written. I'm checking from the Google. It's written that it dilutes the osmolarity. It causes hypoosmolarity.
It is definitely hypotonic, but it is relatively. I think it is. I will try to find a proper answer and I will come back. Okay. So inshallah tomorrow, either I will try to, if it is possible for you people to who are interested, because tomorrow is weekend for me, so maybe in the evening I will not be available. So is 3 p.m. okay for you? Pakistan time 3 p.m.
Yes.
Huh?
Yes, sir, it's okay.
Yes, it's okay.
Okay, so 3 p.m. we will have a session. Thank you very much. Bye-bye. And Dr. Dora, would you like to comment anything?
No, thank you. This is a interesting and complex subject.
Yes.
I had a question actually.
Yes, please.
But it was more of a clinical question of maybe your experience in the diabetes insipidus. Does IV vasopressin work as well as intranasal desmopressin?
Dr. Dora, I have never used it actually. I have never used, because I think intranasal will have a variable effect, I suppose. IV, if it is available, that will be a better thing, because vasopressin, we are using it on desmopressin. I suppose I have never used desmopressin, by the way. So I cannot comment about it because I've never used it. So
maybe someone else has experience.
Yes, Usman, have you ever used?
Yes, I've used once in ICU. Not me, it was a nephrologist who came to ICU and he suggested intranasally desmopressin. Yes, it is used.
Okay, so
okay, thank you.
So actually, Dr. Dora, because you people know that I'm not teaching you people, I'm also learning myself. And this topic is always, by the way, I invited so many people in so many forums. Nobody volunteered. I sent the message, please, anyone who can help me in explaining this topic, because usually I'm extempore. But this topic is beyond me. I cannot explain extempore, and I maybe in some time I will be able to explain in a better way, because this topic always haunt a number of people, I guarantee you. And practically, if you don't know the homeostasis, how to maintain the homeostasis, actually you are playing with the lives. Okay. And yesterday I said the same comment, that usually we are not giving proper fluid, and we are a majority of patients, we are under fluid because we are afraid of making patient overloaded. So usually we should be more confident in giving a sort of not overloading, but at least we should be giving according to the response. If patient is responding to fluid, we should not be afraid of giving fluid. Of course, there is a concept of this goal directed fluid therapy. We are giving some fluid and we are seeing the response. So, we have a lot of resistance regarding putting Foley's catheter in patients. Surgeons, they are not very happy to put it. Practically, I'm telling you, because they have to take the consent and they have to answer, so they don't want to bother. But usually, if you are able to monitor the urine output, this will be giving you a very good idea practically, that whether your patient is in what sort of volume status. This is, I'm telling you, a practical thing. Another practical thing which I will tell you, that if you have this arterial line and you are following this stroke volume variation, it will give you a very good answer to your fluid status. And it is not an absolute number. The trend will tell you. This is another thing. And because arterial line, you will not take in every patient. So there are some monitors. There is a Massimo monitor in which it is non-invasively, it is telling a number by just calculating the variation in the stroke volume. So that is also in, whenever it is possible, I just have a look at it, and it gives a good idea. Okay, so that's my message to you. You see your patient, you see the pulse pressures, you see the clinically, you observe the patient, and it will give you a very, very good answers. Okay, so as a summary of sodium, that we just started from how it is, because sodium is the main, and if we just revise it, sodium is related to brain. Hyper or hyponatremia will cause problems in the osmolality, and it will the brain tissue and brain cells will be very sensitive to it. So this is one thing. And sodium will also is important for maintaining the volume status in the different compartments, ECF, ICF. So for that reason, it's very important to understand. So inshallah, we will start potassium tomorrow. Okay. Thank you very much. And I would suggest to you to listen to the recordings. It may not look very fancy, okay, but I have just tried to explain as much as possible. Okay, thank you.
Thank you.